It was acknowledged that most children who commenced on puberty blockers were then on a pathway. I think there was only one patient within the research study that didn't go on to cross-sex hormones. There wasn't enough care and attention being paid to the child who presented, and it seemed more like everyone already knew the route the child should go, which didn't seem like good clinical care to me. There are so many things I could say that are horrifying about it.
Yeah. What's the most horrifying thing that comes to your mind? So let's just start, if you don't mind. Thank you for doing this. I really appreciate you letting us use your house and everything. Can you start by giving us your name and describe what your position at the Tavistock was?
My name is Susan Evans, and I worked at the Tavistock as a clinical nurse specialist, as a psychoanalytic psychotherapist, and also a clinical lecturer. And I worked in the Gender Identity Development Service for a few years.
Can you tell us what is the Gender Identity Development Service? And can you explain that for our general audience who just doesn't know much about that?
So the service that I worked in, the Gender Identity Development Service, was a very small part of the trust when I was in the Tavistock. And it was a specialist service for children under the age of 18 who were experiencing some form of gender dysphoria. So that is a sort of kind of mismatch or a sense of distress between the way their mind feels about their body.
Yeah, can you dive a little bit more into what that gender distress is? Because it seems to me that that's a fairly new term, and I don't remember people talking about that when I grew up, for instance. Is it a fairly new term?
The language in mental health work, and probably in many areas, changes quite regularly. So when I first went to work at the gender service, I think it had been called the Gender Identity Disorder Service. But then there was an idea that the disordered part of it needed to be removed. And I think, again, we're seeing a change in the way the words are used around this, but dysphoria means a discomfort or some sense of feeling with your gender dysphoria, ill at ease around your gender, your idea of whether you're male or female or a man or a woman.
Right. And I'll come back to that for sure, but I'm wanting to dive a little bit more into the history of Tavistock. So can you give us a little bit of history on how Tavistock developed the JIDS? Is it pronounced JIDS service?
Mm-hmm.
Yeah, can you talk about the history of how that was developed and what your involvement was?
Yeah. So shortly before I arrived at the Tavistock in 2003, there was a psychiatrist working there by the name of Dr. Domenico Di Cellier. And since about 1996, I believe, he had been running the small clinic within the Tavistock, known as JIDS. And as I understand it, back then it was a tiny service that was provided as part of the children and families, but it gradually grew over the years. When I went to work in the service in 2003, there were a team of about 7 or 8 clinicians, and I think we had between about 70 to a maximum of 100 referrals a year for those years that I was there. And of course that number changed massively as the decade went by. When I first worked in this area, the majority of the children, not all, but the majority of the children referred to the service were male. I would say, guessing it was probably 2/3 male to 1/3 female. But it was more common for young boys to express ideas about their gender. And again, that's something that changed massively and was observed by the more recent group of staff who raised concerns about child safeguarding, because what they noticed was that there were more and more adolescent girls appearing in the service.
Yeah, and were those boys, is there data on that? Did they just mostly turn out to be gay? Because I've heard this sort of rumor about this transing the gay away, and I'm curious if that was said at Tavistock, and if many of those boys just happened to be gay.
My understanding is that a few staff working within the service more recently, who were themselves homosexual, were concerned that some of the children coming into the service, as well as having quite complex backgrounds, might also be struggling with what's known as internalised homophobia. But in a sense, it would be young kids who may be noticing something about their attraction, their orientation, and feel that it's too difficult maybe to come out as gay or lesbian. Although in my experience, I've also noticed that there are children that would say, well, I'm okay with that. And often they've been through a period of saying that they're lesbian or gay before they've moved into a non-binary or a transgender identity. But I think the most important thing about it is that children are developing, and we all develop through those years into early adulthood, and our ideas change and mature. And I think the wrong thing is to get too fixed about anything at that early stage. And what I always try and do is just explore however the person might be feeling about themselves, and then just sort of unfold it as we go.
Sure. So when you were treating these kids, was it mostly talk therapy? What was your role exactly in treating gender dysphoric children?
So when I went to the service in 2003, I was already working in the adult department and was very aware of much of the work at the Tavistock. I'd done some previous training there myself as a student. And what I understood as the model of working was largely that one assesses people, meets them, talks with them, asks about their life, about their beliefs, about their behaviours, their feelings and so on. And that the therapy that would ensue would be largely about the relationship between the therapist and the patient. So that the idea being that they would develop a growing sense of who they were and how they felt about life and why they were encountering the difficulties that they presented to the clinic with. Obviously, when I went to the JIDS, my expectation was that it was going to be the same. But actually, I had this really sort of heart-stopping moment not long into my work there when I realised that actually not all clinicians were going to work in a sort of psychotherapeutic way and take time to assess and work with the young kids who were in the service.
Yeah, can you explain what they were doing outside of what you thought would be normal is just talking and having psychotherapy? What were some of the procedures, or were they giving them hormones, or what was happening?
At the time when I was at the clinic, there was a medical pathway for children over the age of 16. So children who presented with gender dysphoria and were deemed to be consistent and persistent in their gender identity were offered a period of time on puberty blockers. And that was often described as a pause for thought or time to think. But in fact, as the evidence emerged from the study that they did, it actually didn't cause anyone really to change the pathway. So I think it was acknowledged that most children who commenced on puberty blockers were then on a pathway. I think there was only one patient within the research study that didn't go on to cross-sex hormones.
Right, yeah, I've definitely heard that. Do you know, and if not, it's fine, but do you know how many kids then go on, whether it's later in life or even at a young age, to surgical interventions?
I don't know how many would go on to surgical interventions, and this is one of the problems in the area. One hears a lot of data bandied around, but the truth is, one of the things that raised our concerns at the Tavistock in 2018 was it became very clear that the experimental work, the administration of puberty blockers to children who were younger and younger, some as young as 10, it wasn't being followed up. And, in any other area of experimental medicine, one would surely be keeping follow-up data, and it was a really shocking part of what was uncovered during this period of time, once things started to be looked at more closely, that they really didn't have any idea what was happening to their patients as adults.
Right. And I'm sorry, that was in 2018?
Yes. So, do you want me to say something about 2018 or what
Well,
happened then?
I wanted to go back actually
Yeah,
just to 2005, because I think you said that was when you first blew the whistle, right? So what was happening then that triggered the something's wrong and you need to say something about it?
Okay. So after this moment where I realised that some of the staff within the team were referring patients on for puberty blockers, after what I felt in my experience was quite a short period of time of assessment, maybe 4 sessions, it's nowhere near enough when you're working with adolescents, in my experience. So then I started to look more closely and listen more closely, and then you start to notice other things, and one of them was that there seemed to be a lot of influence coming in from the charities that had been set up, I think with good intention initially, to support the children and the families. But actually what started to happen was that you became aware that it was what the charities were saying would influence how the clinicians felt we ought to approach things. Things, for example, like pronouns. And I know as time went on that pressure grew to be a lot more. But at that time, that was what I noticed. It was unusual. It wasn't something that I'd come across in such an overt way. And then the next thing was we had a conference, and I should explain that the Tavistock is purely a mental health trust. It was a sort of day patient care. It wasn't a hospital. So it was pretty unique. And the opening address by Lord Carlisle was to say, that it's fantastic that it's recognised now that this isn't anything to do with mental ill health, and really, we shouldn't even be having this conference here at the Tavistock. And there was a sort of big cheer from the audience. And my concern at that point was I had met quite a few of the children by then and heard about a lot more. And, these were kids who had sometimes complex backgrounds. They were experiencing difficulties not only with their gender dysphoria, but with social anxiety. Some of them were being diagnosed as being on the autistic spectrum. So I think for me, it seems so strange that there was this push to disaggregate, really, the idea of the mind being perfectly okay and it's the body that needs to be altered, whereas I like to think more holistically about the relationship between the body and mind. And I believe that each influences the other. So there were gradual concerns. What I noticed was that as I started to raise the concerns, I felt a bit more unwanted or a bit less popular about raising them. It didn't feel like the other areas of the clinic where, one could pose all sorts of questions and sort of, sometimes you'd get people who say, well, I'm playing devil's advocate here, but, can we think about this? It feels a bit unthinkable. But this wasn't anything like this. I think this was just a concern being raised that there wasn't enough care and attention being paid to the child who presented. And it seemed more like everyone already knew the route the child should go, which didn't seem like good clinical care to me.
Right. There's a few different ways we can go from there, but so when you raised concerns, what made you uncomfortable? What was the pushback, or what was the experience that you received?
So I had tried to raise concerns within the team, which I felt was the right way to do it, because that's how clinical teams should operate. But once I realised that nothing really would get taken up or I felt would get changed, my concerns were growing. And so then I went and anonymously whistleblew to the clinical director. I had a discussion with her and sort of let her know what I was worried about. And so at the time, they did organise for Dr. David Taylor to do a report, and he interviewed all the staff, and I think it was a serious report. And in fact, what was striking about the report was that we were never really told, well, certainly I never learned, about the outcomes. We were never shown the report. We were told by the senior staff within the JIDS that they were going to be overseeing our work a little bit more in the child and family, or the adolescent department as it was at the time. We're going to look more carefully at our work. But actually it became clear to me in the following year that nothing much changed.
Yeah, why do you think they buried the report and didn't let you know what it contained?
I've been asked the question about how this went on for so long and why nothing changed. I don't think there's an easy answer to it. I think one of the things at the time was that they hoped that those discussions and the things flagged in the report would get taken up within the team, as would be more customary within the NHS. I think over time, and I mean that they had another occasion when they had an external consultant came in and did some consultation about the team as the years went by. And then, of course, the most recent publicity around the case where the larger group, 10 whistleblowers, spoke with Dr. David Bell in his role as staff governor. But the difficulty was by then, there was always a sort of stock answer, which was the trust would say, well, there's nothing really to see here. You know, we are doing careful work. No one is rushed onto medication. You know, we're experts. And I think that was a worry because it felt like there was a cover-up. So I think I haven't answered the question really about why it never got taken up. But I think that there were also other forces around by then. I think by the time that the trust was relying on the money coming, the income coming in from the Gender Identity Service, I think there are all sorts of subtle things, you know, specialties, you know, there's often kudos around being the sort of leading team in the UK at the time. It was the only team. So there are all sorts of more subtle pressures around. I can't really answer exactly why it wasn't taken up. I just know that it wasn't, and it wasn't going to be really until we decided to step outside of the NHS.
Right, I definitely want to get to that in a moment. So you said that Tavistock used to be exclusively a psychological treatment facility and then they changed. Do you know why it changed?
Well, I don't think the Tavistock thought it had changed. I think, you know, the traditions of the Tavistock, I think they thought they were still following. I think it was just that the Gender Identity Development Service for children sort of, it moved itself slightly outside the norms, if you like, of the Tavistock tradition. And I think it coincided during a period when there were a lot of financial pressures on the trust and everyone's so busy trying to keep their own boat afloat. And perhaps also there is, you know, not a wish to look into the difficulties, not a wish to address that there may be a problem. And maybe fashions change. I mean, I don't think psychoanalysis has ever been that popular because it thinks about the unconscious. But it certainly was popular within the trust, and actually it was popular with most of the patients who attended there. It used to have very high satisfaction surveys from the patients who attended the place. But I just think that in this one area, it just lost its way.
Sure. I'm just wondering if I realize I just don't really have this, if you can shed any more light on, so you talked about puberty blockers and hormones.
Yeah.
Did Tavistock do surgical interventions? I'm actually not sure.
No.
Oh.
So what used to happen with the children, and again, it was a rather odd alliance, was that the Tavistock JIDS didn't do any of the medical, physical treatments at all. What they did was they worked in partnership with another hospital where there were endocrinologists who would then administer the puberty blockers or the cross-sex hormones. But that was an odd situation, and it emerged when we went for the judicial review. It was highlighted much more by that because there was the JIDS who were really the people who were doing the psychological assessment. They were the ones who met the kids and would recommend them to go across to the endocrinology department. But it was actually the endocrinologists who were meant to do the final informed consent procedure. But it was a problem, again, I think, because you're talking about a psychological distress, if you like, something that develops in the mind that is being assessed in the mental health area, but then it's a physical doctor, it's a medical doctor who is going to be held responsible for gaining the informed consent. And really, again, if you've got experience in this area, if there is a young person, a child, I mean, there's a reason we don't let children marry at 13 or 14. And the same would go for this area. You know, there's all sorts of things around in the mind of a teenager who feels so distressed that I don't think will allow them to hear the sense or the real content of an informed consent procedure. I think it's a bit of an oxymoron, because I don't think the staff really fully informed the kids of all the risks. But I also think because the children were so fixed, many of them, on wanting to hear that this was going to be something that would make them feel better, and had been persuaded this would make them feel better, sometimes it did, but very often it didn't, that they just weren't in a state of mind that wanted to hear about it. In the same way, you know, that when a parent says to a child, you know, of 12, you're not staying out drinking with your friends in town, and the kid goes, I'll be okay, because they just aren't in the same kind of state of mind that could hear something that is so important for their future adult life. And I think that's the key thing.
Yeah, so you mentioned marriage, and we have a certain age for that. We also have, at least in the United States, I don't know what it is here, but an age for drinking, an age for getting tattoos.
Yeah.
So everyone, by and large, agrees that it makes sense to put certain limits on certain behaviors. But when it comes to medicalizing children and these life-altering decisions, whether it's hormones or surgeries, we seem to be doing them younger and younger. And I'm just wondering, what is going wrong with society that we don't let them get tattoos, but they can cut off their breasts, or they can get hormones, it's looking from the outside in, it just seems so striking and odd.
Yeah. Trying to understand how the change in attitudes has come about towards the idea of children being able to make such important decisions for their future adult life. And decisions that are going to be irreversible, usually. It's complex, I think, and I'm not sure I fully understand it, but I think the difficulty is that there has been a sort of political, whether you call it an ideological pressure, but certainly there have been groups of people who've put pressure on the idea to young kids and to their parents that this is the right form of treatment. And unfortunately, it's not based on fact. It's based on poor methodological research. It's based on research being done in a way that prejudices the outcome or the answer. None of it really is gold standard. And even the one piece of study that was done that was a sort of fairly serious piece of work, which you may have heard about, which is known as the Dutch Protocol, which is really what has unrolled around the world. Somebody named Michael Biggs has done a big piece of research on this and actually looked more closely. And what you find is that even in their follow-up questionnaires, they were asking questions that would normally be to the opposite sex, but they were asking, say, a boy who's transitioned, are you troubled by your menstrual cycle? And the boy would say no. And so because he's now a girl, in terms of the study, that looks like a huge improvement. Well, of course, a biological boy at that stage is not troubled by his menstrual cycle. So you can see, I mean, that's just one small example of it, but the difficulty is that the belief that this was a good piece of research and that it meant that this was a successful treatment actually isn't really borne out in the follow-up work that's been done in the past decade.
Right, yeah, it sounds fairly sloppy. Can you summarize what the Dutch protocol or the Dutch study was?
Yeah. There was a study done by the Dutch, and it's known as the Dutch Protocol, on approximately 70 kids, and they decided to try out intervening in the process of puberty by administering puberty blockers, and this was deemed to be a successful project, a successful piece of research. What has emerged more recently, in fact, was that it's become known that the follow-up study was actually only carried out on about 50 of the children. One of the children died because of surgical complications to gender reassignment surgery. And the follow-up questionnaires were actually administered to the wrong-sexed children. So in fact, a questionnaire that was asking questions about a girl's gender dysphoria, which might have been about her breasts or her menstrual cycle, was actually given to biological boys. So then when they were asked the question, are you troubled by your breasts or your menstrual cycle, they would answer no, and that looked like a great success. But it was the wrong method, and this has only sort of emerged more recently following the work by Dr. Michael Biggs. And the other thing is that again, the follow-up has not been good. I mean, very few of the adult patients have stayed in touch with the service, and it's more likely the ones that have been followed up. If someone stays in touch, it's perhaps more likely that they're going to be the more successful ones and the ones who feel happier. But many of the people who either feel it's been unhelpful or detransition don't really want to get back in touch with the clinical teams that have been involved in transitioning them in the first place.
Right. So that certainly skews the data, I'm sure. So moving on to, so you mentioned, you raised internal complaints, but then you had to go externally. So can you talk about that? Can you explain who Kira Bell was and then what the case against the Tavistock was there?